I'm Dr. Zafar Iqbal, working intervention cardiologist in an SVD Karachi with no disclosures. Before starting a topic, this is a topic where we will be discussing the different tools of intervention cardiology. Starting from coronary guide catheters to coronary wires, coronary balloons, coronary stents and bioabsorbable scaffolds. And our focus would be on the basically on the design, function and the use of these tools. From the historical perspective, intervention cardiology is a long history starting from the 19th to 20th century. The later half of the 20th century was remarkable, but the first human cardiac cath was performed in 1929 by Werner Forsman, and Andrew and Dixon and Forsman shared for that purpose the Nobel Prize in 1956. The first angiogram occurred, that was by mistake. That was observed by the Mason Jones when he was when his catheter got pulled back from the left ventricle where he was injecting the dye into the left ventricle, and that came and selectively engaged the right coronary artery. So that was the first ever angiogram recorded. The femoral approach, although there was work was going on after that 1958, but the proper femoral approach started in 1965 to 66. In Mason Lab in Cleveland. And the guide catheters were introduced by the very famous guide catheter names like Judkin and implants in 1967. The radial approach was introduced by Lucien in 1989. The first ever balloon angioplasty was a game changer in intervention cardiology, where the real intervention started. That was in 1977 by Grudzik, who performed the first angioplasty and presented his statement in AHA 1977 and got a standing elevation over there for that remarkable revolutionary work. The first ever stent implant was a little bit before that, 1994, but the actual approval by FDA was given in 1994. Starting from the guide catheter, this is the essential tool for coronary intervention, and this is a tube which is a connection between the outside and the inside wall of the patient. Basically, it engages the different ostiums of the coronaries or grafts, and it helps us in the patient pressure measurement and access to the coronaries and contrast delivery for defining the coronary arteries. And obviously, the major and the important one is the device delivery, which is taken through these catheters. If we talk about the catheter design, there are three basic components: hub, shaft, and tip. The hub is actually basically for the attachment of the indiflator. The main structure depends upon the tip and the shaft. And the shaft is that which is made by the nylon. Outer coating is by nylon and the inner coating is by Teflon. And there is a wire embedded in between them that is a stainless steel wire that provides support and torqueability to the guiding catheter for maneuvering that catheter into the aorta. Catheter sizes comes in, there are three types of numbers which we use for the size of the catheter. One is the length, that is the standard length is 100 centimeter, or we also have shorter catheters like 80 to 90 centimeter, but that can also be formed if needed, if not available in the cath lab. The longer ones are 130 centimeter available, used in special circumstances in special patients. The second number comes of catheter size, which is measured in French, and that is 1 French is equal to 0.33 millimeters, and that French actually, that is written mistakenly, the inner diameter, that tells us the outer diameter of the catheter. And the sheath compatible with the guider is that the outer diameter of the catheter is equal to the inner diameter of the sheath. So that comes in a congruent way so that we can use that particular guide with a particular catheter, particular guide with a particular sheath. And the usual numbers which are available in French sizes are from 4 to 9 if we are talking about the guide catheters, to 4 to 9 French guide catheters. For the smaller French guide catheters like 5 and 6 French guides, there are obviously advantages and limitations for larger and smaller guide catheters. If you use small guide catheters, we use less dye, there is decreased risk of complications, there is less radial artery occlusion, which is a very common problem with radial artery access. And obviously, there is a compromise of visualization, support, and device delivery. You cannot perform complex procedures with smaller guide catheters. Larger guide catheters have the limitation of complication and increased contrast use, but for complex PCI, these catheters are mandatory. These are the different shapes of the catheters. There is a quite long range, but in our common practice, we use EBU, XB. By the name, people are quite familiar with that. And implants catheters, JR, JL, Judkin right, Judkin left catheters, multi-purpose catheters. So there are other specialized catheters for different use. Regarding guide selection, it depends upon the access. Basically, it depends upon a lot of things, but if you can summarize it, like it depends upon the access by the vein grafts, the arterial grafts, the lima, and the anomalous origins of the different artery. For we use our common access is femoral and radial. The guides are actually for the both accesses the same guide catheters are used, but with a little difference of the size. As far as the grafts are considered, whether it is arterial or venous grafts, they are mainly dealt by JR and multi-purpose catheter. Sometimes implant catheter is also needed. Anomalous origins like RCA from the left sinus, which we usually see quite frequently, that can be dealt with the large curve of JL5 and AL2. And again, in the same way, anomalous RCA from the right sinus, implants, catheter, and AR and GR are also can be used. RCA, in our common practice, we have seen that it's a very commonly has anomalous takeoffs. For the interior takeoff, we can use larger curve catheters like AL2 and JL. And for downward, or a very famous name, Shepherd Crook, hockey stick and AL or GR3 and 3.5 can be used. For downward takeoff, obviously, multi-purpose in GR can do the job. Talking about the guide support, basically there are two types of supports. One is active and the passive support. The active support is, it is totally operator dependent. It depends about his maneuvers, the operator, like clockwise maneuver or anti-clockwise, pull, push, and device anchoring. But we be aware of that these maneuvers, while deep throating the catheter, can lead to complications. And the passive maneuver, which comes from the obviously from the guide selection, rightly starting from the access to the aortic root to the guide shape and guide size. So that support comes from that. But the term passive is used for the sitting of the cusp on the sinuses, or sitting of the guide on the cusp or the sinuses, or taking a support from the contralateral wall of the aorta. These are some practical points talking about left coronary artery and right coronary artery. The difference between the transfemoral and radial is basically 1 to a half size length decrease in selection for the radial. I mean, if you are using a EBU of 4 for the femoral approach, for radial approach we can use EBU 3.5, or if we're talking about the XB, that is 3.0. So that comes into the equal that. And that also depends upon the support which we take from the different accesses. For the graft study, the catheters are used like GR4, EMA for internal memory artery. And for the left radial, most of those catheters are used, which are used for femoral access. This is a sheath. This is a guider which is now introduced. They have some slender sheaths and some guide catheters which are sheathless. They are used for radial intervention because radial intervention is one of the disadvantages that with conventional guide catheters, we have 5 to 6% of radial artery occlusion after the use of that conventional catheters. And to overcome that problem, they have introduced this sheathless guide catheter, which is a 7 French guide catheter with its outer diameter is equal to the 5 French conventional sheath. So it has an advantage of taking multiple devices and at the same time having larger inner diameter and lesser outer diameter, so can reduce the radial artery occlusion by 1 to 2%. Finally, talking about the complications, we should be aware of that where our tip of the guide catheter is. And our eyes should be always on the monitor, which is outside for this pressure tracing. If the guide catheter size is, large guide catheter size is there, or there is hostile lesion, or there is a deep engagement, we usually see these V wave curve by the name of ventricularization, and the flat curve in the yellow, which is damping. So if that thing occurs, one should be aware of that and to do something about that. Basically, that can be avoided by pulling back the things and looking, and again, engaging the guider in a coaxial manner. Now we'll talk about the guide wires. These are also the important tools. They are basically also made to cross the lesion, goes into the arteries, and the device are delivered on these wires. These wires are made up of different materials and different design. The design depends upon its central coring, distal tip, and surface coating. The standard length is 175 to 190 centimeter, that is usable length. The central core is of two materials basically we used for the formation of guide wire, that is stainless steel and ethanol. Stainless steel has a more support and torque, but it has more kinking problem. And the ethanol, that is flexible, it retains shapes, but it has a less torque. As far as coating is concerned, it is talked about a lot, that is hydrophilic and hydrophobic. Hydrophobic has a good tactile feedback, so has less complications while you are using it, but has increased friction resistance in crossing the lesions. On the other way around, hydrophilic have increased trackability that can be used in tortuous vessels, but has a problem of going into the subintima, leading to the complications like dissection or sometimes perforation. Tips are made up of, they are tapered and non-tapered tips. Usually most of the guide wires are of tapered tip because that increase the penetration capability of the wire. And the another design of the tip is that there is one-piece core or shaping ribbon. One-piece core, these have the capability of increasing the penetration pushability, but they are prone to the complications. Most of the CTO wires have taper tip and one core piece design for the tip. And shaping ribbon is usually softer and flexible. They are used in floppy wires. There are lots of classifications of the guide wires. But for me, I think that would be enough, like coating, whether that is hydrophilic, hydrophobic, and tip load, what you are dealing with. Floppy is like less than, these classifications are all arbitrary. They are not fixed. Floppy is less than 1 gram, and intermediate is 1 to 2 gram, and the stiff wire is more than 2 gram, or hard wires. Wire selection. For simple lesions, we use workhorse wires that has the property of being hydrophobic, low tip of less than 1.5 gram. The example is we use our common cath labs, that is BMW, Cougar, Choice, Floppy. And for non-CTO lesions which are difficult anatomy, like tortuous anatomy or subtotal lesions or high-grade stenosis, we use polymer jacket. We can use polymer jacket hydrophilic wires, but with low tip, because the tip load is not required at that point. So the Pilot 50, Whisper, and Sign Black Filter FC can do that job. For CTO, obviously we use hydrophilic polymer jacket taper tip wires with intermediate to high tip load, because we can accelerate as far as the tip load is concerned. So for CTO integrate, we can start with Pilot 150, and then we can use Fielder XT, and then we can escalate to Pilot 200 and Miracle and Gaia and Confluenza Pro. These all are the wires. There are a long list of the wires that can be used depending upon the tip load and their characteristics. For CTO integrate, which is quite a tough job and quite a delicate job, there are specialized wires that are used for the CTO retrograde, Fielder XTR, Sion, and Whisper, LS, and Gaia first and second. But the Gaia first and second are quite heavy wires. They are rarely used. There are other special purposes of the guide wires, like rotablator wire for rotational atherectomy. We use some wires for coronary physiology, like FFR and IFR. And there are some extra support wires which help us to deliver the devices if the devices are not delivering on the single wire. So we can use an extra support wire to take the devices to the lesion. And complications of the guide wire, obviously there is the wire can lead to the dissection, perforation, wire fracture itself, wire trip entrapment, and subintimal wire entry, which can lead to the dissection. So these are all the dissections one should be aware of. Now we'll talk about the balloons. Balloons, this is also an important intervention cardiology tool, rightly started in 1977. The purpose is dilating the coronary lesions. They can take the stents to the lesions, post-dilating the stents, plaque debulking, calcified lesions, breaking the calcium, delivering the drugs to the desired area and coronaries. That is by the name of drug-coated balloons, and delivering shock waves like the procedure of lithotripsy. This is a balloon hardware, and balloon has material nylon derivative available in 1 to 4 millimeter diameter and 10 to 30 millimeter of length, and the shaft length is 40 centimeter. So the outer diameter is 2 to 2.5 French, and inner diameter is which is compatible with 014 wire. So it can be taken into the conventional 5 French or 6 French guiding catheter, and the hub is for the attachment in deflator. Types of balloons, there are lots of balloons like standard balloons, plaque modifier, stent balloons, drug-coated balloons, small balloons, high-pressure balloons. Standard balloons which we use in our common practice are mainly compliant and non-compliant. And the term compliant, we hear this term quite a lot. That is an incremental increase in the balloon diameter corresponding to an inflation pressure by the volume that the catheter has. The balloons, non-compliant balloons, are mostly used in the post-stent dilatation or to breaking the calcified plaque in patients with CTOs or just having the calcification. And semi-compliants are used for preparing the bed before implanting the stent. These are the other terms used. Nominal pressure. This is a bench test of a balloon under the water with its lowest pressure. And the rated burst pressure is the term that is a maximum pressure at which 99.9% of the balloon will not burst. That is also a bench test. So these all numbers are good to know for the safety profile of the balloon. The tip profile and the crossing profile, the lower profile balloons, like the balloons which come in 1 or 1.5 size, have a very good tip profile and crossing profile. So they can be crossed through any lesion. There are special balloons. Talking about special balloons, we still have this challenge of having very tough calcified lesions, and instant restenosis are quite challenging because they have calcium, they are slippery. So there are specialized balloons made for them, like cutting balloons with having microsurgical blades around them to break that calcium. Scoreflex is 2 wires. One wire is fixed, the other wire is mobile, but with the way it expands, breaks the calcium in a very nice way. And angiosculpt is another balloon which is being used nowadays for the same purpose, is having 3 blades wrapping around the balloon. Drug-coated balloons. These balloons are also a great revolutionary change in the intervention cardiology, and they have been nowadays used quite frequently. But I think Dr. Rajesh has mentioned in his talk about the guidelines. As far as my talk is concerned, the balloon is used in ISR and both for the DES and BMS. And for the native vessel use, it's still in the process, but we can use it in the small vessels. Paclitaxel coated, the drug which is used, that is paclitaxel, that is coated on these balloons. And the clinical data starting from the PACOT trial, which showed which was done in 52 patients. The comparison was the conventional POBA to the drug-coated balloon, and that showed better angiographic results in segment late stenosis was less in drug-coated balloons. And peptide trial confirmed that results. The other trials like Desire-3, Peptide DES, and Peptide China, they showed the survival benefit of drug-coated balloon in DES ISR treatment for 2 to 3 years. So that was the trial which was conducted against the DES. So there is a lot of talk whether to put a stent or to use a just drug-coated balloon is still in the research phase. Possible balloon-related complications: balloon can rupture, can lead to a dissection, stent can be lost, balloon trapping can occur, and balloon shearing off, and coronary embolization and system embolization. These all can occur with balloon. Now we'll talk about the stents. The basic mechanism of the action of the coronary stents are common to all platforms: enlargement of arterial lumen by scaffolds, tagging of intimal flap, and sealing of dissection. These three major problems were covered by the stents like BMS, but the BMS has one limitation, that it has a high number of new intimal hyperplasia, and that was overcome by the drug-eluting stent, by the antiproliferative agent used on that stent. There are 3 different forms of stent platforms: stainless steel, cobalt, chromium, and platinum alloy. But cobalt, chrome, and platinum alloy, these are better stent platforms because they have a less nickel and thinner struts, so they have a less incidence of in-stent restenosis and stent thrombosis. Stent design also has, there are some stents which have closed cells and open cells. Both have their advantages and limitations. Closed cells have advantage of coverage, the luminal area, better radial strength, but they are less flexible, difficult to deliver. The open cell has great flexibility, easier access to the side branch, but has weaker radial strength, less coverage of the vessel wall. So depending upon the cell size, they have their limitations and advantages. Stent types. These are all the stent types, rightly starting from the BMS. But the platforms for all the stents is the same, rightly starting from the BMS. As we discussed in the last slide, that was stainless steel and chromium and platinum alloy. So, but the DES, as far as the DES is concerned, we had early generation, early or first generation DES, that was sirolimus eluting stent and paclitaxel eluting stents. Now they are not used. And now we use new generation stents like sirolimus eluting stents, zetrolimus eluting stents, and Resolute. And the antiproliferative agent, mostly on these stents, the new generation stent is a limus family, which is antiproliferative proliferative are used. It is mainly the limus family, and the drug aims to limit the new intimal hyperproliferation. DES data. There are large number of trials conducted, but every trial has been compared to the BMS or early generation stents, and everolimus eluting stents have shown better results in comparison to the DES, and better comparison to the BMS and early generation stents. And Resolute integrity stents has a similar angiographic and clinical outcomes compared to everolimus stents. Covered stents. The special stent of the use is, that is the one we use. These stents are called graft masters, but they are also come in the different names, are used for coronary perforations. And there are few latest stents like retinol IC, dedicated bifurcation stents. They are also used sometimes for bifurcation. This is the fourth revolution that was considered to be the fourth revolution in intervention cardiology. As you can see that in this angiogram, the stent has been deployed, but we cannot appreciate where the stent is deployed. Basically, the stent is deployed in the proximal LAD. That is a bioabsorbable scaffold. And the other picture is of bioabsorbable scaffold. These are the different platforms: Ikagai, magnesium alloy, Riva stent, ideal stent, and dissolved scaffolds. These are the major randomized control trials in comparison to the DES, absorb, randomized control trials, FEM absorb, spirit trial, reabsorb FEM. These all trials showed one thing which was in the favor of bioabsorbable scaffolds, or BVS. That was restoration of vasomotion, endothelial function, less instant late luminal loss, suppression of restenosis by everolimus, and increased luminal area and the minimal luminal area. That was all achieved by this new revolution that is bioabsorbable scaffold in comparison to the DES. But the current BRS are composed. Of either polymer or bioabsorbable metal alloy. Despite the favorable results of the early Stent, the technology failed to develop due to inability to manufacture an ideal polymer and timely resorption of the studs. An important limitation in the past has been the polymer-mediated occurrence of severe local inflammation leading to neo-intimal hyperplasia. The potential drawback is the stent fracture. What happens once you apply these stents and you place it on the nominal pressure? Most of the times their studs get fractured, or with the passage of time these studs get fractured for certain reasons. The clinical significance of this is not to this is to be further elucidated, and the stent fracture should be avoided by respecting the nominal size of scaffold. In all absorbed randomized controlled trials, because these trials were conducted all over the world in different regions in different area, published rate of device thrombosis were numerically higher for absorb trial, while meta-analysis of the first 6 trials reported a 2-fold increase in the risk of device thrombosis with absorb at 1 year of the follow-up. And absorb scaffold, which is presently the only BRS with randomized data for clinical outcome versus new generation DES. The negative results of the clinical trial, the manufacturer decided on the worldwide halt to sale of the absorb scaffold as of September 14, 2017. And with that, I will end my talk. Thank you.